Hi, I'm Charles Wykoff, and it's an absolute privilege and pleasure to be here with a good friend in the retina space, Arshad Khanani. He's Director of Clinical Research, Sierra Eye Associates in Reno, Nevada. Arshad, you're incredibly involved. It's amazing how much you're involved in across the retina space. And we're here today to talk about an exciting new development retina. So thank you for joining us.
Thanks, Charlie, for having me. It's always a pleasure working with you in latest and greatest clinical trials, and I'm excited to talk to you about Faricimab.
Awesome. So exactly. So Faricimab, we've been talking about new agents in the field, new MOAs for a long time, right? Anti-VEGF monotherapy has been a revolution for what retina specialists can do for our patients over the last 10 to 15 years. But now there's a new kid on the block that does more than just inhibit VEGF-A. We have Faricimab, as you pointed out. So in particular, we're going to focus on the very recent wet AMD phase 3 data. But Arshad, give us a high-level overview of what Faricimab is, and then we'll dive into wet AMD.
So we have been involved with Faricimab during the early days, Charlie, just like you. And it's a bispecific antibody, and one arm blocks VEGF-A, the other arm blocks Ang2. And we have enough preclinical and clinical data that blocking Ang2 leads to stabilization of vasculature, decreasing inflammation and leakage. So the idea is the fact that can we go beyond just anti-VEGF blockade, and can patients benefit from it? And especially we're going to talking about neovascular AMD. Can we decrease the treatment burden for our patients so that they can maintain vision in the real world? As we know, that's always a problem where patients lose vision over time.
Perfect. Great summary. Thank you. So now here we are, the first time ever in retina that I'm aware of where there's been two major phase 3 programs reading out publicly at the same time, right? Their DME data set and their wet AMD data set, both with two massive global phase 3 trials. So the wet AMD program is composed of LUCERN and TENAYA, these identically designed trials. Tell us about the design of these trials and what's special about this phase 3 program.
So the design of these trials was really done based on the guidance from the phase 2 trials. So let's talk a little bit about Avenue, where we saw the Faricimab every month or every other month, where patients did well compared to ranibizumab. And then the Stairway study, where I was involved a lot in designing it, where we looked at patients treated with Faricimab, looking at Q16 week and Q12 week dosing. And this was compared to monthly ranibizumab. And really, I think the best trials are the ones that are designed based on good phase 2 trials. And that's what was done for TENAYA and LUCERN. As you said, these large global randomized phase 3 trials. The only difference was the comparator arm. In phase 2, we used ranibizumab, but obviously in phase 3, aflibercept was used on label because that's the most utilized anti-VEGF currently and has a better drying effect than ranibizumab. So the idea was, can you go head to head with an agent that is first line? So in these trials, patients in Faricimab arm received 4 loading doses. And the idea of 4 loading doses came from phase 2 also, where we saw that patients who received monthly treatment actually continued to have improvement with 4 loading doses. So patients in Faricimab arm received 4 loading doses. Patients in aflibercept arm received 3 loading doses per the label. After that, there were disease activity assessments in the Faricimab group at week 20 and week 24. One thing I want to highlight is the fact that these were pretty strict criteria, meaning you have OCT, you have vision, you also have exam, and then also investigator judgment. So when you are putting this data in to IXRS, they would ask, do you feel like there's worsening activity? So all of those combined gave us these disease activity parameters. And then if patients had disease activity week 20, they went into Q8 week dosing. If they had disease activity at week 24, they went to Q12 week dosing. And if they didn't have disease activity at all, they went into Q16 week dosing. And once they were in the swim lane, they stayed in the swim lane. So I think something to keep in mind that patients are not dropping from or going up and down throughout the trial. They are staying in the same lane they were in initially. And then aflibercept was given per label after 3 loading doses. Patient received treatment every 8 weeks.
Fascinating trial design and very well described. And then the primary endpoint is an endpoint that we're all still learning about, which is the concept of averaging visual acuity over multiple time points at weeks 40, 44, and 48. And describe to us why that is. Why do we have to average multiple time points? Why can't we just look at a single time point?
So the reason that was done, Charlie, was the fact that you didn't want to quote unquote game the system with giving a loading dose before the primary endpoint, because we have seen that in some trials where patients don't get enough treatment and then they get treatment 1 month before the primary endpoint, and then their visual acuity improves a little bit or their CST improves. So that's why I think the idea was really scientific design to really get good data, and then giving all the faricimab patients a chance to show their visual acuity benefits and OCT benefits, as well as Eylea treated patients. So I think it was a very fair endpoint. By averaging those time points, we're able to get good data and good idea about comparing faricimab to aflibercept. So I was very excited to see that, because as you said, in other trials, it has never been done.
Great comments. So then tell us what you saw. What are the visual, the anatomic, the durability? What did you see? What were the outcomes?
So when you look at visual acuity, this was a non-inferiority design for neovascular AMD. And the reason was, people asked, like, why didn't we go for superiority? Well, that's why good studies are designed on solid phase 2 data. And in Avenue as well as in Stairway, we didn't see a superiority for faricimab compared to ranibizumab in those trials. What we saw was durability. And I think, as you and I both know, as busy treating physicians, durability is the biggest unmet need for our patients with neovascular AMD. So that's why the trials, were designed as non-inferiority, but of course, less frequent dosing up to Q16 weeks with faricimab. So what we saw comparable visual acuity gains, as well as comparable CST reductions. And I know we're going to talk more about it, but the idea is that about 80% of patients in faricimab group went Q12 week dosing or longer. So I think that's the key for the audience to understand, that you're really having majority of the patients that are treated with faricimab after 4 loading doses. Now they can go every 3 or every 4 months, which I think is very helpful for our patients in decreasing their treatment burden. And when you look at OCT, Charlie, you and I, treat patients based on OCT, and we really want to see that if the vision is comparable, how is the OCT going to look like? Because we don't want to undertreat these patients in trials and see a lot of fluctuations in OCT. And the good news is that, in my opinion, it appears that there is a slightly edge for faricimab, especially during the loading phase. You can see there's a little bit greater reduction. And then the fluctuations I see in the faricimab group, and remember, 80% are on Q12 or longer dosing, and the fluctuations are less. So I think it's exciting when you look at the non-inferior BCVA gains, and it appears to be a trend towards better drying with faricimab with less frequent dosing. So I think overall, pretty exciting data.
Fascinating. And obviously we the whole field got to see the DME data simultaneously, which really kind of resonates and echoes what you just described, which was a good durability signal and possibly an edge with anatomic dryness. Was that your interpretation of the DME data as well?
Well, absolutely. And you did a great job presenting it. It was a phenomenal presentation at Angiogenesis. And I totally agree with you. We as physicians who are involved with trials, the data has to speak for itself. So not only comparator data in each TENAYA, LUCERN, Yosemite, Rhine, but also data from both trials. I mean, there's clear indication that this is a more durable agent compared to aflibercept, and it appears, as you said, a trend towards better drying. And you don't have to be a game changer in terms of drying or in terms of durability, you have to do better than what we have. It's a step-by-step approach to help patients. We're not gonna overnight change completely how we treat patients. So I think people are still gonna give intravitreal injections, and once it's approved, I think there's a potential for Faricimab to be the first-line agent based on what we have seen in the trials.
Really practical comments, super helpful. So we're all super keenly aware of safety nowadays, right? We've all dealt with safety issues in early phase trials and unfortunately later phase trials and real world, treatments as well from multiple agents, right? It's sort of the tip of the iceberg is of course Faricimab, but there's others, right? Abicipar, and then many of the agents under study. We were thinking a lot about inflammation. And I think that, fortunately, the whole team, the whole global team here around Faricimab has tried to be very transparent with all of the safety data. What's your interpretation of the safety data so far from TENAYA and LUCERN in particular?
I think safety is crucial, as you said. We are not going to use an agent if it's better but has worse safety than what we have currently. The good news is, based on my evaluation of the data that you and Jeff presented at angiogenesis, based on my experience in the phase 2 trial, it appears that the safety is very comparable. So if you look at events of IOI in the phase 3 TENAYA and LUCERN, in TENAYA, in the Faricimab group, there were 333 patients, and that was the total number of patients, and only 5 had an event, so 1.5%. And in the aflibercept group, there were 336 patients, and 2 had events of IOI, which was 0.6%. But in LUCERN, Faricimab had 331 patients, and 8 had IOI events, which was 2.4%. And then for aflibercept, 326 total patients with 6, so 1.8. So on average, IOI rates were about 2% or so in Faricimab group and 1.2% in the aflibercept group. The other thing you and I look at, Charlie, is there any vasculitis? Is there any retinal artery occlusion? Those are the things we look at, because those are irreversible events sometimes that lead to permanent vision loss. But the good news is that that was not the case. We only had 1 retinal artery embolism in LUCERN in the Faricimab group, and that was actually a Hollenhorst plaque. So there was 0 cases of retinal vasculitis or retinal artery occlusion. So based on that evaluation, and also looking at the DME data you presented, it appears that the safety is very comparable, which is good news for our patients.
Great. It's a great summary of a complex data set. Absolutely agree. And my last question for you, what's next? I really applaud the whole global team again with Faricimab for setting up long-term extension studies to begin with. I love that, because a 2-year, even a 3-year phase 3 program, like some of the past DME programs, is the beginnings of understanding what these patients are going through. But really, longer term data is crucial as we understand these medications and the way patients respond to them long term and the durability signals. So very happy to see that there's a 2-year long-term extension study already in the works. What's next for Faricimab in wet AMD?
I think you put it really well. You said that we need to have long-term data, because not only we need that in general, but also for a new mechanism of action. The question is, can we have better efficacy or better durability as we go longer? Because, blocking Ang2 leads to Tie2 activation. Can that have long-term effect on fibrosis? Because there are some preclinical studies showing that. So I think you and I both treat these patients on a daily basis. We see after 2 years, 3 years of treatment, patients can have fibrosis and other things that can lead to vision loss. So I think it's really exciting that the program is going to go into the long-term extension phase, the AVANEL-X study. But also in the second year, Charlie, you have PTI, personalized treatment interval, that is going to be implemented. So we'll have that data next year. But I think overall, looking at the data, I think what's next for Faricimab is hopefully we can have this as a treatment option for our patients with the neovascular AMD as well as DME. You and I are getting busier and busier, and especially in the COVID times, we need to make sure that not only patients get adequate treatment, but they don't come to our office or clinic as much. So hopefully this will decrease the treatment burden for our patients. So I can't wait for it to be commercialized and hopefully available to use in clinic.
Great comments, Arshad. I always learn a lot. I appreciate the discussion. Look forward to more.
Thanks, Charlie, for having me, and looking forward to working together and really having Faricimab as an option for our patients. Thank you.